Hello and welcome to RIVE, Reflections in Veterinary Education. This episode was my turn to pick an article. And so we're going to do a journal club today. And the article I have selected is from human healthcare world, but I think there's a lot of really good stuff in here that applies to us. And so the article is Supported in Independence, the Role of Supervision to Help Trainees Manage Uncertainty. And this is Jonathan Ilgen and co-investigators. And it is in Academic Medicine from 2021. And I actually, I found this article. It was on a list of best of the year from another academic journal. They were like, hey, we're not including any of our own articles, but like, hey, here's a curated list of medical education, here's the best of kind of a thing. And so I skimmed through. I was like, that's a great place. Somebody else has done a lot of work to find some cool articles. And so that's where I found this, and I was like, ooh, I kind of like this. And then as I kept reading, I was like, oh, even better, it's emergency. But that wasn't the reason I picked it. But I thought that there's some good stuff about clinical training, and also it's a qualitative study. So I thought there's a little something for all of us to enjoy. But so that's the article I've selected. And I guess we can go through, I guess we can start. I feel like I've done all the talking so far and neither of you have said anything yet. But we can start with any initial thoughts on just the article itself, and then we can kind of go through the, overview.
I really enjoyed it. It was actually one of the shortest qualitative papers I've ever read, and I was really impressed with how much they packed into it. I thought it was a pretty well done study. I mean, there are always little things here and there, but I was like, oh, okay, this is actually really good. So that was a pleasant
Yeah.
surprise.
Yeah.
We'll get to it, but I feel woefully inadequate as a mentor after reading this. I'm like, oh, I don't think I do any of this.
Oh no, I bet that's not true. But I do, yeah, I agree, Catherine. I picked it and I shared it with y'all before I really read it. I read the abstract, but then later when I saw the length, I was like, oh no. I had the same thing. I was like, oh no, this is there's gonna be problems. But I was also pleasantly surprised at their ability to create a qualitative a research study and then keep it really concise, but like you said, pack a lot in. So yeah, so we'll start just by kind of going through the idea. And when reading it, it was part of it, a series. It sounds like of studies where they're talking to different people in different roles, both supervisors, and for this study, they were talking to trainees. And so wanting to kind of understand from trainees, okay, you're out there in an apprenticeship style learning environment, and you're in this kind of weird mid, I think I highlighted one of the first sentences. So you're talking about trainees who are expected to assume responsibility for patient care, while often being the least experienced member of a healthcare team. And that statement really resonated with me because we do that all the time, right? With our trainees, with new interns, first year residents, we put them in situations to have a lot of responsibility, but they're very much in between. And so they wanted to talk to these people who are in that kind of in between. You're a qualified doctor, and you're given a lot of responsibility, but maybe more than you're ready for. And so they wanted to talk to those individuals and hear from them how they manage the uncertainty. So when you aren't confident in your own abilities, how do you manage that is kind of the situation that they are trying to home in on. And so I'm trying to forget my numbers, how many people were involved, but it was across, I think, 2 institutions, and it was, the number doesn't really matter, right? It's qualitative, but they talked to a variety of trainees, and they would interview them. They had a semi-structured interview after one of their shifts. And they did end up being emergency shifts. And they were like, okay, we want you to recall a scenario where you felt like you were a little bit out of your comfort zone, and then talk me through that. And how did you manage that? And what happened? And then another scenario where you felt confident, and talk me through that. And how did you handle that? And then, they went through, and they were very clear about, as as the study went on, they adjusted that semi-structured interview to try to like change things to get at some of the things that they were coming across with the specific intent of finding things that were different. Like, okay, we don't want to hear the same thing over again. Let's try to tease out things that might be different in the next person we interview. And they interviewed the same people multiple times as well. So it wasn't like one person, one shift. So there were a number of interviews with individuals who enrolled in this study as participants. And then they went back through using constructivist grounded theory approach, which I don't know that I'd come across that where it was a constructivist grounded theory approach. I think most people just call it grounded theory. Maybe that was because they anticipated not everybody who read this would know where that's coming from. I don't know. But at any rate, so they use grounded theory to go through the transcripts of each of these things and code all of the transcripts of the dialogue of the conversations and come up with themes that they kind of then went back through. And then that's where they went through in the results, the analysis. And there were a few things that I had to, like, I was like, oh, I'm going to look this up. I wasn't familiar with this. So it's always fun for me when I come across something I hadn't seen before. So I had to do some Google searches to learn about a few of them. But maybe it's worth just talking about grounded theory and like what that approach is, or anything else y'all want to talk about. But that was one of the things I thought might be worth digging into.
Yeah, so grounded theory is one of those approaches to qualitative research that I think a lot of people think they know, but then it kind of gets misinterpreted. And so for me, grounded theory is this idea that you're diving into information and you're using that information in a way that helps you to either add on to an existing theory, change an existing theory, or create your own theory of whatever it is you're discovering. I think what most people think of grounded theory as is like, oh, you don't have any specific questions. You're just diving into the material and it kind of tells you what it wants to tell you. And there's some of that involved, but it was essentially created initially by, I think it was Levi and Strauss, but they basically said, no, it's like you're analyzing all this material to try to figure out how to evolve a theory or create a theory of your own. And so I was a little worried they were going to fall into that sort of, yeah, we're just going to dive into it and not have a real question, but they actually used it appropriately. I have not seen it titled constructivist grounded theory myself either. And so I'm not exactly sure why they qualified it that way, but yeah.
Yeah. Okay. I'm glad because
I'm so glad to hear you say that, Catherine, because that's always been my criticism as well, is like, I thought that grounded theory, we use the data to create the theory, but that means that we need to articulate at the end of that process what that theory is, which is the step that I see missing a lot of the time. And I think that there's like a distinction between, like, I think that when a lot of times when people say they're using grounded theory, they're actively using like a deductive reasoning approach to this existing theory, right? They're applying this deductive approach to the data informed by this theory, which I think is different than grounded theory, which is like, I'm finding the theory in the data.
Yes, that's exactly right. Yeah.
Well, and I think to emphasize what you said before, Catherine, it doesn't mean you don't have questions or like this is what we're looking for or whatever. It's not just like, oh, let's see what happens, throw some, paint against the wall and see what sticks. But it's different from like, hey, we have a hypothesis that this is, applying in this scenario. And so we're going to look at it through that lens. You're basically saying, I'm not totally sure what lens we need to use in order to interpret and analyze this. But as we go through the analysis, if a theory, arises and we go, oh, this theory makes a lot of sense, then we're going to use that and either say this is how that works, or like you said, maybe amend it or tweak it a little bit. Or if no theory that you're aware of happens to kind of naturally come out of that process, then yeah, you might need to create a new theory because something, which makes sense, right? Because until you've gone through it, you might not know, and that's how new theories get developed when nothing seems to fit quite right. But yeah, it's not just like, we'll just tell you what happened and we won't really think about it critically.
Exactly.
I had a strong experience of this where we did a study looking at students' decision to go into private practice versus internship. And so, we had all these interviews and did this data and we're kind of teasing it out. Like it was all like values-based sorts of decisions. And like as we're doing it, I'm like, God, this looks familiar. Like, what does this look like? And then I'm like, there's relatedness, there's
Mhm.
competence, there's
Mhm.
autonomy. This is self-determination
This is
theory.
self-determination.
Yay.
Yeah. Yeah,
Yeah.
so
Yeah.
sometimes you can use grounded theory to help you identify this is actually the theory that aligns really nicely with what we've found. But you didn't know that until you analyzed the data. Yeah, cool. No, I think that's super helpful to kind of go through. And like you said, I think they did a nice job in this particular study to kind of go through that. One thing in the methods, so that there was just a very, very short one sentence paragraph at the end of the methods that just said, throughout the data collection and analytic processes, our team individually and collectively reflected upon the ways that our past experiences impacted how we made meaning from our participants' narratives. Thoughts on that?
So I was glad that it was in there, but I would have liked to have a little bit more meat to it.
Yeah, yeah, yeah. I mean, I think it's good that they have that reflective statement, but it was kind of like, but well, I want to know what your past
Yeah.
experiences were and how they like. Tell me because
Yeah,
I'd like to know.
exactly.
Like, thanks for acknowledging your biases, but like they're your biases, and so
Yeah.
if you don't tell me what you think they are, then it's hard for me to interpret how that may have influenced the results. So that I agree. I was like, it was cool that it was there, but also it felt a little bit brief. Thanks for acknowledging it, but I wanted more from that too.
There was not a true like author
Mhm.
like reflection statement in the
Right.
methods.
So yeah,
Um,
normally like, or I think what we are all saying we would like to see is that each author, right, like each person that was involved in data collection and analysis would write a blurb about, okay, here's my training, here's my background. And they did give us a little bit about the different authors. Like I think two or three of them were clinicians working in the clinical, and then two of them were educationalists, researchers. And then it
Cognitive
wasn't clear.
psychologists, I think they said.
Yeah, that's right. I
Yeah.
think you're right. So not clinicians and kind of part of that, but so they did provide that background. But I would have liked just a little bit more about each of them to, what's your training, what's your interest in this, and yeah, what were your biases? So that I could have beefed that up a little bit too. Um, let's see. So then,
I did like that they described that they made notes throughout their
Yeah.
analytical process of like the decisions that they were making. And I
yeah,
particularly appreciated that because having been in these discussions where we are like digging into qualitative research, like at the end of it, we're like, ah, okay, great, we arrived at this thing. We didn't really clearly describe how we did that, number one. And number two, sometimes we forgot. Like we'll
yeah.
go back to the data 6 months
Why
later.
did
It's
we
like,
choose this?
oh, how do we do this?
Yeah,
Yeah.
yeah,
Yeah, the memoing is really important. I was glad to see that they put that in there. And I think that's one of the things too. I think it was this group we were discussing about doing manual transcription versus
hmm,
doing, Otter AI or something like that, which I mean, Otter AI is great and it's great to not have to spend the time, but when you really have to manually transcribe something, you really have to dig into that data more. And if
yeah,
I go back and look at, for example, my dissertation notes, I mean, there's memos all over my paperwork and just sort of, oh,
yeah,
it sounded like he was saying this, but it really was this, those kinds of
yeah,
things that you miss out on. So yeah, it was nice to see that they really talked, and they didn't necessarily specifically explicitly say that they doing this iterative process, but they sort of interwove that throughout their narrative,
yeah,
talking about how they went back and rechecked things. And even it looked like they had 9 participants. They felt like they'd reached saturation. They did 4 more just to make sure. Like I thought all that was,
yep,
it wasn't as explicit as somebody who was wanting to maybe redo this, like
yeah.
try to do the same kind of thing, probably wouldn't be able to do it based off of this paper, but I think they at least had many of the elements that are often missing in these types of
And it was
studies.
kind of like, hey, if you wanted to reach out to us, we have all of it.
Yeah.
Like I
Yeah.
think that it was pretty good. Like this information is available. We didn't necessarily put it in the publication, but it could probably be available if you requested of the
Yeah.
authors, which I think is helpful because otherwise, why do you tell us you did it, right? Like, hey,
Right.
if you need it, here it is. Because
Right.
also I could see that being something that in the review process, right? They may have included a lot of that stuff, but this is, given like the journal that it's in, right? It's in academic medicine, which again, you've got it's academic medicine, but it's not like specifically an education focus. Like we know who's reading this, and like maybe we want to cut. I could see that happening at the editorial stage
Yeah.
where reviewers were like, "Meh, we don't want all this." Um,
Right.
so it's certainly possible that's why it was mentioned the way it was. Um, I
I
appreciated
did.
the
I
shout
also
out.
appreciate.
Go ahead.
Go ahead, Bobby.
Oh, I was going to change topics, so go ahead.
Okay, I was just going to say I like their sample size description
Mhm.
as well.
Yeah.
I think that we don't often like. I think that when I usually read papers and when I've written them, I'm like, oh well, these are the numbers that we got, and we reached saturation with that data set because after a while we're like, yeah, nothing new is coming out of this.
Yep.
But this was a much more efficient. This is like a good 3R way of doing it. Is
Yeah.
like collect your data, analyze it, be like, okay, do we have enough? Maybe we do. Let's get some more to see if we find any contravening data.
Yep.
I like that approach, and I might just steal that, honestly. Be
Yeah.
like, yeah, let's do that.
I think it's,
Yeah,
yeah.
I liked it too. I will say though, going back to one of the comments you made, Bobby, about them saying that they sort of tweak their research,
Mhm.
their interview questions, which I mean, it's perfectly acceptable to do that, but in some ways, it makes I think they had to go back and do those extra 4 interviews because the initial 9 that they did weren't all the same. And so
Yeah.
if they didn't pull all the same questions and pull the same information, then they wouldn't necessarily have known that they had reached saturation with the questions that they finalized at the end of those interviews. And so doing those last 4 was really smart because then they were like, oh yeah, we really have refined it. It was kind of
Yeah.
like they did a pilot within the study and then
Yeah.
went ahead and refined it and redid it.
But
So
using the pilot data too.
right. Yeah. Yeah. So I do think it was a very efficient way to go about it.
Mhm.
And yeah, it's certainly something that I would consider doing in the future as
Yeah.
well.
Yeah. I thought it was good.
The only thing I found, I don't know, were you planning on going on to like the conceptual framework and procedures specifically
Yeah,
or?
but that's okay.
Okay. There's just something in the procedures that I thought was really weird. And they talked about having the interviewees draw pictures of their
Yeah,
incidents.
that
And
was
I
one of
was
the things I had to look up.
like, where did that come from? And
And
why
it
did you
didn't
do
sound
that?
like it
And
worked
then
really well for them, but
yeah, and then they were like, and we couldn't really get anything out of it. So
yeah,
all of the
that was
data.
one of the side things I had to look into. It was like, all right, what the heck is this about? I wasn't, yeah. So we'll talk about that one a little bit as
Okay.
well. So I was just going to say before, again, going through their conceptual framework and some of the things they were thinking about, they just a nice shout out to Vygotsky and the zone of proximal development.
Yeah.
And I think it really does apply really nicely here. I know a lot of Vygotsky stuff is more children, right? And that development, but I think that applies. I mean, that's what Vygotsky specifically was doing, but I
Yeah.
think it's a lot of people look at the zone of proximal development as like, yeah, that is where learning happens, right? You got to get a little bit out of your comfort zone. This is, what can I do with support, right? The things I can do with support today, theoretically, I can do independently tomorrow, right? And so that's where we need, not literally tomorrow, but that's where we need to push our learners is to get that growth, not out of their zone, but at any rate. So that was just a nice reminder. If that's not theory that you're familiar with, it's probably a pretty good foundational one to be. I said theory, not Siri. My phone was like, what?
Yeah,
So
I think
something to kind of review.
the great thing about Vygotsky is that he really was, in many ways, really far ahead of his time. I mean, if you look at the neuroscience of learning now, they talk about the state of safe emergency, which is essentially the zone of proximal development in neuroscience language, right? Like you need to be in this area where you're challenged, but you're not challenged so much that you shut down, but you're not challenged so to the point where you're bored, right? So
Yep.
it's like, anyway, I think it's really
It's
interesting.
good stuff, right? If you're not familiar with it, you need to go read about it.
Yeah,
It's
for
kind
sure.
of the point. So they didn't belabor any of it, but if you look at that and you're like, huh, you should read that. That's pretty foundational stuff. Yeah, we already kind of talked about population and their sampling strategy. Yeah, so the procedures, there were a few things that I had to look into. The one thing I think is worth discussing, they emphasized in a couple spots here the desire to, at least for the recruitment, to make sure participants felt really safe. And so because of that, I think they did conversations via Zoom, but the cameras were not on. And so when it comes to kind of like, what are your all's thoughts about that, right? The pros and cons of just having the audio without any video in the analysis piece, I guess is where I'm going with this.
I'll let Eric go first.
Well, I think that it depends on the analysis that you're doing, right? So there are analyses that you might do where you're looking at your nonverbals as well, your proxemics, all the other sorts of things that go on with human communication besides the verbal. I don't think most people do that analysis, but that is out there. So that's, would not be captured by just audio. I think, I think that now this was 2021, right? So this
Mhm.
was like still early days of the pandemic when maybe
Yeah.
people weren't as comfortable with video
Well, this
conferencing as
was,
they
yeah,
are.
it was published in 2021. I'm trying to remember exact. I think it was late 2020 where they actually conducted the interviews, if I
Did the
remember right.
work, yeah. But I'm
But yeah,
thinking like
very
I
pandemic.
I actually find it a little off-putting when I'm communicating with someone and their video is not on. I had a call recently where I didn't expect that to happen and the person just never turned their video on. I'm like, yeah, it's weird. It's
And
weird.
did you have yours on?
Yeah.
Yep. Yeah,
But if I had mine off, like I don't know, like
I
why
agree.
don't we do a phone call?
Exactly.
Like what's the point of using this technology?
Agreed.
Yeah, I agree with everything that Eric said. I do think that there are other ways that you can guarantee safety, or not guarantee, but that you can encourage safety that would allow them to sort of see the nonverbal gestures and cues that are happening. I mean, it's very possible that a lot of these folks are sitting there and they're like, whatever, and they're thinking that and they're showing that and they're nonverbals, but they're saying something else. And sometimes you can pick that up and sometimes you can't. So when I'm doing things like this personally, I like to give them the option of that and just remind them that, whatever video is being recorded and audio would be deleted and those kinds of things. But yeah, I mean, I can appreciate why they did it. Um, I think, yeah, I think it depends on individuals and sort of what it is exactly they're looking to get out of it. But I agree, like if you're not going to put your video on, then you might as well just do a phone call. I mean,
Yeah.
what's the point?
I don't remember. I guess I don't know if they said one way or the other. So if they did, I missed it. But it wasn't clear that the interviewer, they may have had their camera on. I don't
Yeah.
know. But yeah, I think that does make for a weird interaction if you're doing it via Zoom, but not seeing the other person. And you do miss something, right? By not having the video. Whether or not you're going through and specifically analyzing that, can certainly have an impact. But yeah, I think you just got to acknowledge it. It's a choice that was made. I think that's fine. And again, I went back and it was like September to July 2020.
Mm.
So like, yeah, they were like, whatever we can do to get people to enroll in this. I can imagine that was a fraught time in the world in general and in medicine in particular.
Yeah, that also makes me wonder too about the self-selection of the individuals that chose to participate in this, right? Because one of the things that I was thinking about a lot is they're talking about discernment, and there's this statement on S81 that says trainees expressed a pervasive distrust in their own acts of discernment, which to me is like, okay, well, that means to me that those individuals are probably the higher performing individuals, because if you think about sort of how we self-assess ourselves and that Dunning-Kruger effect, the people who are the worst at what they do tend to rate themselves much stronger, and the people who are the best at what they do tend to rate themselves less strong. And so I think there is, and this is a qualitative paper, and so that's fine, but there probably should have been some sort of acknowledgement of the selection of individuals who chose to participate. And that may or may not, this I guess is all related to the fact of it may or may not have made a difference in regards to the safety factor, right? So
Yeah.
like if you feel like you're not very good at what you do, they probably felt like they needed to create a little bit more of a safe space. Whereas if you're maybe not good, but you're not really aware that you're not good, you may not care as much.
Yeah.
So I don't know. It would have been nice to have a little bit more exploration of that and how those trainees were viewed in terms of in relation to their peers that maybe didn't
Yeah.
choose to participate.
Fair. Okay. I did want to talk about the stories. What now? I can't remember what it was called. No, not the critical incident tip, but rich picture methodology.
Yeah.
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 So that I had to look up, but basically the very brief gist of it, unless one of you has more familiarity with it, then okay. It was essentially encouraging if you're trying to get a story from somebody, giving them some time to say draw it out, and it doesn't have to be like a drawing, but like it can be a schematic, it can be whatever. But we want you to visually represent what you're trying to describe, and then you're going to talk us through that. With the idea being that the process of having to depict it can get people to kind of think more deeply about it, and you might get a richer description of the thing. So it's not about the art, that's not the point of it, but forcing participants to kind of apply what they're thinking in a different medium, essentially. And so, yeah, so that's kind of the theory or the thought process behind rich picture methodology. And so they had asked the participants to do that, to draw their visual representations, pictorial representations of the situations that they were going to describe, and then go through that. And then later they were like, yeah, I mean, we think it helped the participants, but we didn't really get much out of analyzing the things that they drew. So it was like, so unclear how much of a benefit they really got from that. Curious your thoughts on that, if you'd had any experience with rich picture methodology before. I had to look it up. I wasn't familiar with it at all.
I've never seen it in a research setting, but I have in a patient setting with our marriage therapist. We did a session where we did this, and it was actually pretty cool. Like I was surprised at how effective it was in just using a different medium to communicate information. I'm not surprised it was not valuable to them. I'm just thinking if you ask me to draw that, what that would look like, it would not be useful data. I can tell you that much.
Yeah.
Yeah, I feel like this is probably coming from the cognitive psychologists, right? Like they're like, oh, let's do this because we do this with children who have gone through traumatic events and don't want to describe it, right? So I guess now that you've described it, it makes sense that that's what it would do. But I think back to my own traumatic childhood and people wanting me to draw pictures. I'm like, why would I do that? Ooh, gross, But I certainly think I mean, I'm glad that they mentioned it, and I think that it was interesting that they were willing to explore it. Now, there is literature that supports like art drawings can certainly help enhance learning and things like that. And so I don't know if they were kind of coming at it from that angle, but it was just a little bit, it just seemed a little bit odd to me, but I mean, it's fine. It's not bad. It's just different.
I got the impression it was one of those things, hey, this could be really cool. And then they got it like, this didn't really add much, so we're just going to mention it. But and again, I could see how, like you said, Eric, getting participants to think about it in a different way could be beneficial. Like giving them some, if nothing else, it forces like a little bit of reflection time to like, okay, you have 10 minutes. We're not going to talk about this. We just want you to think about this. And so that might have been helpful in and of itself, which is kind of what they said. They're like, we think it kind of helped the participants really kind of dig in a little bit more, but the drawings themselves were not particularly useful for us analyzing the data.
Yeah, I'm trying to think about how you would draw a scenario in an emergency room in which you were uncomfortable. And I'm thinking about my own stupid stick figure drawings and what that would look like.
Yeah, and I'm like using symbols and arrows and frowny faces.
Exactly.
And yeah. So I'm just like, I was thinking the same thing, like, what would I draw if I were in that situation? Which I can imagine the first 7 minutes of that 10 minutes they were given was like, I don't know how to draw this. What
yeah, exactly.
About? Next thing you know, I'm drawing a kidney because I just don't know what else to do.
Right.
So part of me was like, can I get some of these drawings? I'm just curious what they look like. But I'm not sure they're necessarily pictures so much as, again, it could just be words and schematics, just, thinking about it and sort of, I don't know. But anyway, it was a fun little like side quest for me to be like, okay, what is this? And I always like when I get to learn about something I hadn't been familiar with. So that was cool. Anything else in the kind of methods that you all wanted to highlight? Yeah, Eric?
Just real quickly, because it stood out to me when I read it. They asked them 2 questions at the end of their shift. An instance where they felt challenged but able to handle it, and a situation that made them sweat, where they felt over their head or needed to relinquish control. And I know ER is obviously different than anesthesia. Like anesthesia, our residents do 1, maybe 2 cases a day. And so I'm just thinking like the number of times when even a first-year resident gets into a situation where they're over their head and needing to sweat, like that is not a shift-wise occurrence or daily occurrence. It's hopefully probably a weekly occurrence, but I just thought that seemed optimistic to me. But maybe if they're in a busy ER, this happens more commonly.
Yeah. I would say on an ER shift, that didn't cross my mind. It wasn't like, oh, there's no way they're going to have those situations, because it could be like a micro situation. It could be like just the conversation I had with this client. Maybe it wasn't even the case that was a challenge for me, but like, how am I going to talk about this? They don't have the money for X, Y, and Z, or oh, you know, I don't have this drug available to me because it's after hours. So like, what, it might not even be like, I'm not sure what medical decision to make, but sometimes it's just logistical things. So for me, I think if you have a reasonably busy emergency service, I feel like you're going to run into these things for often enough.
I would say that most ERs, human ERs, are busy enough that they're going to run into that pretty regularly. I think it's very different in human medicine versus in, you know, veterinary medicine, where people are having to pay out of pocket. Whereas, you know, especially in something like maybe it sounds like these are both academic teaching hospital ER situations where they're going to treat whatever comes to the door, whether they have the insurance or not. Like, I would imagine there's more opportunity to be overwhelmed than not in those situations. And I mean, it can be overwhelming in a veterinary clinic, right? Even if you're in a teaching hospital, but particularly like the first year when I was out doing ER, there are sometimes you're just like, oh shit, do I know what I'm doing? You know, like it happens. But I would imagine, especially because of the lawsuits and all the stuff that happens with human medicine, there would be times where it's like a little bit crazy. And yeah, it may be just those microcosms of like, I just didn't know how to handle this particular patient, or I couldn't
Yeah.
understand what this person was doing, or, you know, whatever. So
Or the
I
family,
think
right? Like, yeah.
Yeah, I think I'm thinking of like I walk into the theater and I'm like, oh, holy hell, what have you been doing for the past half hour? You know, and I have to take over. Like that's kind of, you know, I'm like,
Yeah.
yeah, you got in over your head.
Yeah. I think those on a smaller scale are happening a lot more frequently. But even in like
That's
one
fair.
anesthesia case from start to finish, it could be such that like I couldn't get
Yeah,
the art line in, right? Like that could be
right.
it for one case. Or I didn't realize, you know, like it could be an equipment thing, it could be a communication
yeah.
thing. Like there's a lot of
Oh,
scenarios that I think could come up even in one anesthesia case.
yeah, for sure. I
Yeah.
mean, and this is obviously not in a teaching hospital, but even when I was in private, I think I've told y'all before, when I was in private practice, my second or third year out, I was working at a corporate practice, and my medical director had me, who I had pretty good experience at that point, and then we had a new one that had come on, a new veterinarian that had to be like in the 6-month program, and I was working with him one day, and he was doing surgery. He was doing a spay on a dog, and I hear the technician come ringing out, Dr. Fogelberg, we need your help. I'm like, what's going on? They're like, the dog's waking up. What do we do? And I'm like, what do you mean? What do you do? And the doctor, I walked in, the doctor was like standing there like this, had stepped back from the table, put both of his hands in the air, and was just looking like a deer in the headlights. And he's just looking at me, and she's like, I don't know what to do. The technician's like, I don't know what. I'm like, propofol. Let's
It
get some
needs more
propofol
drugs.
into that
Yeah.
catheter. Let's put the dog, because the abdomen's open, right? Like, let's get the dog back to sleep. And then I'm like, all right, take out that, you know, let's deflate that cuff. Let's take the tube out. Let's re-intubate, like, right. And so that doctor in that situation was in over his head. Like, he
Yeah.
shouldn't have been, but
Yeah.
he was literally standing there like a deer in the
Yeah.
headlights with his hands in the air and open abdomen and looking at me like, what do I do? And I'm like, that's not somebody who's ready to be in practice yet. So
Mhm.
yeah, I think I mean, hopefully that's never happened to you, Eric, but in your practice. But I mean, this was a licensed veterinarian. He passed
Yeah.
NAVLE, you know. So yeah, I think you're right, Bobby. I think it could be even just a small thing
Yeah.
like that. And
But I
I
wonder, yeah, if you were to ask your resident at the end of each day, right,
yeah.
these questions, you know, would they struggle to come up with scenarios or not? And if they would, then they're not hanging out in the ZPD enough, right?
Right. Or they're just not admitting it. They're just
Right,
not
right,
admitting, like, because they don't want to admit that they were. And I think
right.
there was a little bit of that in the article too, right? That they
Yeah,
just, some of them just didn't want to admit that they needed the help. And
yeah,
so that may be the case. And I find that to be pretty prevalent in veterinary medicine. I don't know if that's true in human medicine, but certainly there's this like, I can't ask for help, then people are going to think I'm dumb, or people are going to think I'm weak, or, you know, whatever
yeah,
litany of reasons that they give for not asking for help.
yeah.
So. Or maybe they just don't like you, Eric, like you said. Maybe they just don't, you know. I'm totally kidding. I don't believe that in the
That's
slightest.
my top differential.
I don't believe that.
I don't think so either. Oh, that's funny. Um, okay. Any other conversation regarding methods, and then we can move into the juicy results. All right. So I like the way they organized the results. I thought it was really nice. So they went back and were like, okay, here are kind of the themes that emerged. And then they kind of gave us each section and then went a little bit into it. They did a really nice job of using, quotes throughout. So some really nice exemplar quotes from participants. I thought just the way this section was organized was really nicely written. It flowed nicely. So kudos to them for that. This idea of borrowing comfort. I just like that phrase as well. Yeah, Eric.
I just reading some of this, I'm like, my students have literally said this. They are like, we were in this situation and we looked up and you were standing there calm and we're like, okay, I guess it's okay.
Yeah, yeah. I think it was super relatable, but I'd never heard the phrase borrowing comfort, and I
Yeah,
love it.
same.
I think
Me too.
it's just that phrase alone. You're like, yep, I get what they're saying.
Yep,
They
yep.
of course expanded on it and did a really nice job of explaining and giving examples, like Eric you just did. But yeah, I think we do that a lot, right? We turn to somebody who we trust and who we were like, okay, this person knows more. Are they panicking? Okay, I guess I don't need to panic. Why it's so important not to panic, right? When you are, especially when you're in charge, is because when you panic, everybody around you panics.
Yeah.
It's like, hey, all right, let's just bring. I mean, I'm sure you've had the same experience, Eric, and I'm sure you too, Catherine. Like, okay, an animal, or like, hey, the animal's waking up. What do we do?
Right.
Well, first thing, let's panic. Let's all just panic,
Right.
run around, arms in the air. That's definitely gonna, right. Like the first thing is, okay, let's assess the situation, right? Like, what are we doing? All right, there's, this is why we train for things. This is why we, train for CPR. This is why we train for triage. Blah blah blah. Get back to that. But yeah, if I start to panic, everybody around me is just going to go bonkers, right? So borrowing that comfort, it was a nice way to kind of capture that sentiment, which I thought was great.
When in danger or in doubt, run and holler, scream and shout.
Or if you're
I
on an
love that.
airplane, just look at the flight attendants. If the flight attendants are panicking, it's time to panic.
Yeah. You might as well, yeah, see if you can make some phone calls. It's like you're in trouble
Right.
now. But yeah. um, Awesome. And then the strategically invoking support, right? And trying to figure out how they would get the support. There were some subcategories in this one that I thought were really cool. Broadcasting, right? So this is like, for me, I love this, just modeling or like verbalizing what they're saying and doing. Like, here's what I'm saying. And then like checking for feedback. This is your opportunity to assess me. But if I hear nothing, this is the really important part about feedback though. The assumption that if you don't say anything, then it's because I'm doing everything right. So the power and importance of feedback, because a lack of feedback is sort of this implicit, you're doing it right. And that is how it's being interpreted by the trainees. So really important. And then the pantomiming, which at first I was like, I don't know quite what they mean. But yeah, very, very similar. Like, okay, it's kind of similar to the broadcasting, but you're like, I'm not broadcasting to my supervisor. I'm explaining to somebody else and I'm like looking over like, hey, are you hearing this? Like, and then checking for like an A-okay, or you're gonna correct me, right, if I'm wrong. So I thought those were nice examples of real things that I think we've probably all seen people do or done ourselves in various scenarios. Any thoughts on either any of those?
Yeah, I thought I love that idea of the borrowed comfort. I like the idea of the talk, because we talk about, clinicians, it's really important to talk out loud and sort of narrate what you're doing and those kinds of things. I think it's really interesting that they didn't ask for help, right? They didn't directly say, I feel in over my head, I need help. They were just sort of testing the waters by saying things out loud and hoping, right, that their supervisor would then give them some sort of feedback, whether that's no feedback or ooh, or you know. And so again, that leads me to wonder, are they really not comfortable asking for help, which I think would be an interesting subsequent
Yeah.
question, because they do talk about like needing to take comfort from their supervisors, but they don't talk about necessarily being comfortable asking directly for help and
Yeah.
saying, I feel like I'm in over my head. Can you give me some feedback about this? Or I need help. And then having the, supervisor say, no, you're doing just fine. Right. So
Yeah.
the fact that they had to do it indirectly, I think is a really interesting
Yeah.
finding for me.
Which is a nice segue into the next section. Actually, we're talking about when they didn't feel supported. I mean, in some of these instances was when they explicitly asked for help. It was like, hey, I don't know what I'm doing. I think the one quote was like, I don't know what to do. And she goes, you should probably figure it out, and like walked away. So maybe
Super not helpful.
maybe that is, but from the supervisor's perspective, it might have been, you're doing fine. Like, I don't want to handhold you, right? Like that could be their thought process. Not saying it was handled that well. That's honestly not necessarily even what happened, but that was the interpretation of the trainee, right? It might have been like, you're doing fine. Like, because I've had that before. I'm like, why are you asking me this? You know what you're doing.
Yeah.
And so how was that interpreted by the trainee versus what was intended by the supervisor? The supervisor might have been saying like, you've got this, figure it out. Like, you're totally fine. And it was interpreted as, I'm not helping you. So, that those human interactions are really interesting. But clearly that particular trainee in that instance was like, I didn't feel like I had the support, which probably does influence whether or not they're going to ask that person explicitly for help next time. So
fair.
what I agree with you, Catherine, it would have been nice to tease out, like, how do these specific interactions affect what you're going to do next time you work with that person, right? Like, are you going to then try more pantomiming or broadcasting and hope to get your feedback more indirectly? Or are you just going to shut down and avoid that? Like it would have been nice to try to tease that out some.
Yeah. I was just saying, this reminds me of one of my classmates, super, super smart. She's a boarded internist now. But we were in our first year physiology class, and we had finished our exam review, and there's just this one question that she just didn't understand why her question, like her answer was wrong. And so she raised her hand. She's like, I just don't understand. I've read several other textbooks in addition to the textbook that you gave me. I can't figure out why my answer is wrong. Yeah. And the professor just kind of looked at her and said, well, you just have to find your way to the answer. and she was like, well, okay. And so obviously she never asked him another question, because she was like, he's not going to help me at all. So yeah, I think that's a really good illustration of that same situation. I think in his head, that's not how it came out, but to all of us, we were like, that's how it came out. So yeah. You just have to
immediately my head goes, you don't know the answer either.
Yeah.
And this is where in the beginning, I'm like, oh, I maybe not such a good instructor. Like, they'll be working on something, like they'll be working on an art line and they're like, I can't hit it. I'm like, I don't know, it's in there somewhere. Like, that's the extent of my feedback. I have nothing else to say. Like, there's an artery in there somewhere. You got a catheter, stick the catheter in the artery, like, I don't know. Sometimes I'm just like, when they're trying to do an ultrasound guided nerve block and they're like, I can't find my needle. I'm like, I don't know. Like, you gotta find it. Like, these are things where I like, yeah, maybe, but I don't know what to say. I have thought about, especially with the ultrasound, like I might need to talk to the radiologist and ask them the words that they use, because this is such an intuitive skill to me. I'm like, I don't know, you get the needle and you see the needle. Like, what do I say to make this better?
So my question for you, Eric, is when you're in that situation, is it because you're observing them and you're like, you seem like you're doing everything right, you just got to keep playing with it? Because I've had that same thing when I'm like trying to help a student do just collect blood or place a catheter. You're like, it looks like everything you're doing is right. I don't have anything specific to tell you to do differently other than keep trying and hope to get lucky. Like, I mean, literally those are things I will say. But presumably, if you saw them doing something that looked wrong, you would correct that.
Right. Yeah, that's a good point.
So maybe it's just being more explicit.
Yeah, a lot of the times, like, they won't be successful. I'm like, I don't have any advice for you. You were doing all the things that I would do.
Yeah, and I think that's fair.
Yeah, I think that's fair. But I also think that is a really good reason why sometimes specialists are not the best people to be teaching these things, right? So I really, really, really wanted to teach adults how to read, right? Like when I was many, many decades ago, it was like my good deed is like, I love reading. I want everybody to be able to read. I know how hard it is to get along in the society without being able to read. And as I got into trying to teach these individuals how to read, I found I was like crap at it, because I've been able to read for a really long time. Like, how am I, as somebody who's been able to read since I was 3 years old, how can I explain what comes so intuitively to me?
So much of this has become automated.
Somebody who like is having a hard time recognizing individual letters, and then recognizing diphthongs, and then recognizing why though is different than enough, right? Like it's hard to do. And so I think it's one of those things where, and again, goes back to your point, Bobby, is like maybe those individuals that individual didn't feel supported, but in fact, that supervisor was like, well, I didn't have any better advice to give them. They were doing just fine, but they just
It
didn't
didn't verbalize
articulate
it.
it right
Yeah.
that way. And so I think it's really good for us to be considering these types of things, because as we're then giving feedback to individuals, we can be more explicit about it, right? Like, Eric, you may go back now and be like, listen, I know it feels like you're struggling, and I can understand that because I struggle too. And unfortunately, you're doing everything that I've done. And it's just one of those things, you're going to have to do it over
Yeah.
and over again to get there. Right.
Yeah.
So maybe it just takes
Yeah.
a few more words.
Yeah. From my end, it looks great. Next time, be luckier. Like,
Yeah, right.
I don't know.
Exactly.
Which, again, you can kind of make jokes about it, but to say like, it looks like everything you're doing is right. But I have also struggled with what you're saying too, Eric, where like specifically for me, like when I'm in surgery,
Yeah.
I don't have the words to tell you. Like usually I'm like, okay, I need you to hand me the instrument so I can show you what I'm trying to
Yeah.
explain, because I don't have the words. Whereas like a surgeon has done that enough that maybe they can verbalize it. So I think talking to a radiologist, I've worked with some radiologists who are so good at articulating what they want you to do with the probe, an ultrasound. I was like, oh yeah, that totally makes sense. Like I didn't even realize I was doing that because I've just like played around with it so long, and eventually, it moves. But being able to say, oh, this is the ways that you move the ultrasound probe, and this is how you get these different things. But yeah, breaking it down into those little steps can help. But yeah, I think that was for me the big theme was verbalizing what I'm thinking more than I do now, to try to make sure the trainees they're not leaving them to guess, which is really funny.
Yeah.
I did
I would
want
also,
to, oh, go ahead.
oh, I was just say there was one section in here where they talked about, I think one of the participants had said something about like, it was really good to see that I can't know everything and that my supervisor sometimes needed help too, right? Because I'm thinking about too, so I was just in a hospital mentoring somebody who had a large dog spay, and the dog was just bleeding. I mean, it was just a bloody dog. It was just one of those dogs that was just bloody. And he had done everything right, but the dog was just still oozing way, way more than I would deem acceptable. And so we dug around in the I mean, that dog was open from sternum to pubis. We're digging around in the abdomen. We're trying, we found both the pedicles. Everything looked fine, but the omentum was just really bloody. And so there was some kind of vessel somewhere that was bleeding. And every time we would find something, then it would still bleed. And so at one point we were digging in there, and I'm just like, you know what? We got another extra hands in here that's really experienced. Let's bring them in, right? Like, we've been digging around in here. We haven't figured it out. Let's bring somebody else in. And I think it's, I mean, I was in a mentorship role, and I think it was really important for that new doctor to see that I'd been in practice for 13 years and I still thought it was a good idea to bring in help. And so I think that was one of the other sections in here that I thought was really important to highlight, is that, sometimes you are in over your head, and sometimes I'm in over my head, and sometimes 3 or 4 heads are better than 1 or 2 heads.
Yeah.
And that's okay. It's better to ask for help than it is to just
Yeah.
kind of still blunder around and screw something up.
Yeah. Well, and I think the trainees expressed they were comforted by that, right? Like knowing that their supervisor was also like, yeah, this one's just tough. They were like, okay, it's okay for me to feel a little overwhelmed because this is just a tricky situation. But so being explicit about saying like, yeah, this is a really tough one. I'm not sure how this is going to go, right? It's okay that you're struggling because I don't have all the answers either. So I think that was also really good to normalize that, and that did provide the trainees with some comfort, right? That was
But
also
not panicking, not
yeah,
panicking.
no panicking, never panicking. Okay, there's the last quote in this section. I just the first statement I want to say. I want to see what your all's thoughts were on this. So this was the quote from one of the trainees. This was in the section of experiences of insufficient support. I think I would have felt more independent if I felt like the help was more available and more accessible. I don't know about you all, but I read that I was like, I would have felt more independent if I had been less independent. So I read that. Which I just thought was, I don't know, maybe that's me being really biased from like the supervisory standpoint, but I was like, I would feel more independent if I knew there was somebody there to pick up after me.
Well, but I mean, it makes sense to me, right? Because
I know.
You're going to feel a lot safer on a high wire if you have a net versus
Yeah.
if you don't have a net. And most of the time, you're not going to need the net, but it's nice to know that it's there, right?
Yeah.
And so I think that I get where you're coming from, because it does seem sort of counterintuitive, but especially as a young, new sort of practicing doctor, I can get that. And I think it may be more about not feeling like they were supported, right? Because they do finish, because I had that last one said I felt like I couldn't really have independence because my help didn't feel secure, right? So
Right.
it probably sounds weird, but I sort of get it, right? Like
No, I do, but I think for me it was important from my perspective to think about it in the terms like that's how a trainee is feeling, where I'm looking at that and like, but if I'm there holding your hand, then I'm you're not being independent, right?
right.
Like, and so how are we striking that balance? And having the conversation is really
Yeah.
important, right? Like,
But you don't
hey,
have to,
I
you
want you
can,
to be independent. You call me if you need me, right? I trust you to recognize when you need help, when you don't. Here's how I'm available, because I think that could have been enough to fix this, this feeling.
yeah.
But
Yeah, but I think there's something very different about having somebody right there, not necessarily holding hands, telling you how to do it, giving you like the, oh, you're doing great, but having somebody in the building compared to having somebody that you have to call and wake up and go through all those feelings of like, oh, are they going to be really upset with me because I called them at 1 o'clock in the morning, and then they're going to come in and they're going to be like, well, why did you call me in? Because you should already know, right? Like, I think
yeah,
that's a whole different layer of stress. Whereas if there's somebody in the building, even if they're at the opposite end of the building, you
yeah,
know they're awake, you know they're there, you know they're
yeah,
working, and that gives you maybe a little bit more confidence to act
absolutely.
independently and do things that you might not be as comfortable with because you know they're there if you need them, but you don't necessarily have them right next to you. So
Yeah.
I think from that perspective, that's sort of the perspective that I took. Again, I'm not a specialist as a GP. I have seen this more often than not, that they really just want somebody there. They don't
Oh,
necessarily.
100%. They all want somebody there. The
Yeah,
problem that I run into as a supervisor, like, I don't have the caseload to justify paying two people to be in the building, right? Like,
sure.
I cannot justify, like, I actually like working overnight shifts. Where I am at right now, Virginia, Maryland, our ER service is not nearly busy enough to have even me by myself, right? That would be a
Yeah,
waste of time to see two cases in, 10
yeah,
hours on average, like probably a little less than that on average. So to have me there in the building or somebody else in the building with this, like, can't do it. Like, we don't have the resources for it because we're not
sure.
busy enough for something like that. But 100% they want it. I mean, like, we
Yeah.
heard that from our interns this last year. Like, like, we want somebody here. I was like, yeah. So how do we navigate that? Right. There's the
Yeah.
realities of the world. And so um, that's where, I kind of come at these struggles a little bit too. Yeah, we'd all like to have, a buddy nearby. And I do understand that. Like, that was super helpful for me. Even when I was an intern, like having just another intern mate. They don't even have to
Yeah.
necessarily have a lot more knowledge and expertise, but just being able to bounce ideas off of somebody, it's just not always practically available.
Yeah, I
It
get that.
makes me think of with the more complicated blocks that we're doing nowadays, like I like my residents just to let me know that they're doing
Yeah.
them. And a lot of the times I'll just like, they'll have the machine out in the kneel. I'll just kind of like saunter on over, just kind of lean against the thing and I'll
Yeah.
look at it. And I will just say nothing at all. And then
Mhm.
they'll do their thing and I'll walk away.
Yeah.
Um, and partly because like I want to see like how good of a job are you doing? Like, do you know
Yeah.
what you're doing? And partly like I just want
I'm
them to
here.
know that they can ask,
Yeah.
for
Yeah.
these more technically challenging sorts of
Yeah.
things.
And I'd be curious to ask those trainees at that point, like, hey, did that make you feel more secure or less secure? Right. Because
Yeah,
I
right?
imagine some of them are going to say,
Yeah,
oh my God, that was so intimidating that he walked into the
yeah,
Yeah.
room. And others like, oh, it was so helpful to know that he was there. And you're like,
right.
I can't win.
Yeah.
Can't win.
Well, and I think too, in a situation where you're in an emergency room for humans, it's going to be quite a bit busier. And again, you have a
Yeah.
little less worry about the staffing part, right? Because
Yeah.
you're seeing enough cases and you're
Yeah.
managing that in a way that's very different than when you're seeing two cases overnight
Yeah.
in emergency
Yeah.
clinic. Um, but I do think then when you're out in private practice, if you're going to have somebody working like the first night I worked in overnight, I was completely by myself and I was probably
Mhm.
6 months out, and I had said I was ready to do it and they felt like I was ready to do it.
Yeah.
But I also knew that there was somebody there I could call if I needed
Yeah.
them. I didn't
Yeah.
necessarily, but I mean, I was older than most people when I went into practice, so I didn't necessarily need that person in there. But had that been somebody else, they might have wanted to
Yeah.
have practice where they had more than one person there, even if it
Yeah.
wasn't a direct supervisor. So,
Yeah.
I mean, I think it could, based on sort of the caseload and the individual staffing, and I can certainly see where that would be an issue. And I would guess, an intern probably a lot more likely to want or need that than a third year resident. I would hope. that
Sure.
that,
Oh yeah, for sure.
right?
And I've worked in both, scenarios, right? I've worked in super busy hospitals where we can have multiple doctors in the building overnight, and there's advantages to that.
Yeah.
But then it's also a super busy hospital, and it has its own challenges, and there's different things. So yeah, it's a tricky scenario. And then, as you just illustrated, Catherine, not everybody needs or wants the same thing, or I should even needs, like, wants the same things. And I think that's when we run into issues, when what a trainee wants, and or thinks they need, or maybe does need, is not in alignment with what the supervisor thinks they need. I think that's
Yeah.
where there's some friction. And again, I think there were like instances where this was sort of hinted at, but not directly explored, like the mismatch between
Yeah.
trainees and supervisors, and what kind of
Yeah.
kind of a scenario is best for training and for patient safety.
Yeah, absolutely. I mean, I certainly had a mentee that was that way. I mean, this mentee has been out in practice for 2 years now and is a phenomenal, actually phenomenal doctor. I mean, does really good work, but does not feel like they do really good work. And so they feel like they need to have somebody there to hold their hand the entire time. But in reality, the perception is that this individual is so capable that they don't need it, but she desperately wants it, right? She
Yep.
doesn't need it, but she wants it.
Yep.
And so
I've had
there's
many of those
definitely that
scenarios.
mismatch. And that's probably a whole different conversation about how do you manage that type of
Yeah.
situation. But yeah, I
But
mean,
it's a struggle.
it
It's a
is a
real struggle,
struggle.
because the other thing, I've had trainees come back and say, well, it's not appropriate for me to be managing these patients. Like, they're not getting the care they need. And it's like, how do you plan? Like, how do you think I learned how to do this? How do
Right.
many of us learned? That, it is about finding the balance. And to be honest, we don't always get it exactly right.
Right.
But if we never push you to be independent, if we never get you in that zone
Yep.
of proximal development, you won't develop, right? Like,
Right.
if you're only doing what you can do independently, like that's the whole theory, right? Like, if you're just
Yep.
in that, I can do this independently, I'm not being pushed out of my comfort zone at all, you won't progress.
Yeah,
Like, that's
exactly.
the problem. And so when people
Exactly.
get uncomfortable in that, what should be the zone of proximal development, where, like, they're not beyond that, you can do this with some support. Then if they don't feel comfortable in that zone, I don't know how to solve that, to be honest with you. That's a
I'm not
tricky.
I'm not sure you can solve that. I think that's a whole nother conversation
Yeah.
about confidence and competence and all that
Yeah.
crazy
Yeah.
words we throw
But I do
around
hear
that we
that
don't
coming
really know a
up
lot
a lot.
about.
I hear that coming up a lot with trainees, like, well,
Mm.
yeah, I shouldn't be managing these cases, blah, blah. And it's like, but how are you going to learn how to manage these cases?
Well, I mean, I do think a lot of it is that fear of making a mistake. And so, when I'm talking to new graduates or fourth year graduates, I'm like, listen, you're gonna make a mistake.
Yep. Y'all got to
You're
get
gonna
over
make
that, because that's
multiple
part of the
mistakes.
job.
It happens. It's part of the job. If you got
Yeah.
into a job where you thought you were going to be able to be perfect all the time, you got another thing coming. So you just
Yeah.
need to get really good with making mistakes and figuring out how to fix them. It doesn't mean you should just willy-nilly make mistakes, and you should definitely
No.
try to not do that, but
Yeah.
it's know that it's going to happen,
But also, that's where you got to put your pride or your fears aside and ask for help when you are
Right.
feeling that way, right? And
Yeah.
say, but not like, I can't do this. Just say, hey, here's where I'm at. Here's what I'm thinking. Like, this is where you check in with the supervisor and
Right.
say, what have I missed? It's not,
Exactly.
I can't do this and throw my hands up.
Right.
It's, I think I've reached my limit. Here's what I want to do. What have I missed? And if they go, no, you've done everything right. Great. Keep going. Okay. Then we're in the right zone. Or, hey, you've done one little tweak and then we're good. Right.
Right.
Okay, cool. We're in that zone and we're progressing. But if you call me the next night for the same scenario, we have a problem. Like, there's got to be some progression, some development. So if it's not related to the scenario, but it's just, no matter what, I need help, that's something we have to
Right.
address differently. And like you said, maybe we can't solve that, but
Yeah.
I don't know. But I do see that
So
more.
I have the exact opposite problem.
Ooh, let's hear
And
it.
I've been sitting here thinking, I wonder if this is specialty dependent.
Mm,
And if so, that would be really cool. My problem is that my residents are I don't know if I'd say excessively confident, but they believe their level of expectation of their independence is higher than my expectation for
yeah.
their level of independence. Like,
Mm,
they're like, "Oh, I should be able to handle this case." And then they do, and like, on call, I'll be like, "Oh, do you need help? Do you want me to come in?" They're like, "No, I got it." And like, no, like, I'm here to help you. And
yeah.
and then they'll be like, "Oh yeah, the case, was on norepi and this and this and this." I'm like, you needed to have called me,
Yeah.
like, uh, and I don't know if that's like cultural in our program somehow, or if that is like because technicians will run anesthesia very competently. If
Yeah.
they're like, oh yeah, like I've done a vet school, I've done an internship, most of them done,
Yeah. I can do all the
anesthesia,
things.
advanced training. They're like, yeah, I could run a,
Maybe.
C-section or whatever.
Yeah.
Like I don't need my faculty there. Um, so I don't know. That's
It
really
is
interesting to
interesting.
think.
One kind of confounder I'm gonna think, like right now what I'm talking about are rotating interns, not residents, because I don't have any residents yet. We have one starting in a couple months, so I'm
Ooh,
excited.
exciting.
Oh,
So is some of that because they're rotating interns? So
oh,
they
for
haven't been
sure.
like, I
Yeah.
want to do ECC, right? Because when I think back, to when I did have residents, I think there was a mixture, but I think there was less of this, I can't do anything, like I need somebody to help. I think that's a much more intern or like first year, out of school kind of a thing,
Yeah.
less for a resident who's now in their chosen specialty.
Yeah.
But I also wonder how much of it is, what's happened in the last 5 years, and what are the results after COVID, and
Right.
so it would be interesting to look at that, and we'll have to circle back, when I look at, as we build up the residency program. So I think that's at least part of it, is the difference between a rotating intern who's on ER and maybe doesn't like ER, right? Like that's not their jam, but they're also younger in their training. So yeah, I don't know.
I
Uh,
think it's probably the bell curve, right? I mean, I think that there are
yeah,
individuals who are going to be on this edge of like, I can't do this. I need help all the time. And even you're going to get interns and residents that are that way. And then you're going to have those folks who are sort of in that middle who are like a little bit more self-aware, but maybe not as self-aware as they need to be or as confident as they need to be. And then you're going to have this group at the other end of the bell curve. They're like, oh, yeah, I can do whatever. No, I don't need any help. And so I'm thinking about a story that Micah just told me recently where she was working with a first year resident who was doing a surgical procedure and it was a fairly routine surgical procedure, but she had actually, so it was a laparoscopic spay, and she had actually nicked the spleen. And
mhm.
so when Micah was in there helping her, she was like, "Well, I'm pretty sure you nicked the spleen. We just need to go ahead and open her up." And she's like, "No, I've never nicked the spleen before. Why would I do that? I don't think that's what's going on." And Micah's like, "No, I'm telling you. Like Micah's a surgeon. She's been residency trained. She's been doing surgery for
Yeah.
over a decade. She knows what's going on." And she's telling this first year resident, like, we need to open this dog up. This dog is bleeding too much. You've nicked the spleen. She's like, but I've never done that before. So why would you like that can't possibly be what's going on? And it's like, this is clearly somebody who doesn't understand that she has made a mistake
Wow.
and will not admit that she's made a mistake. And so
Yeah.
finally, Mike is like, listen, we're opening up this dog, right? So they opened the dog, and sure enough, she had nicked the spleen. And so then this intern was or resident was like all embarrassed and wouldn't talk to her. And it's like, listen, everybody makes mistakes. You just have to listen to the people. It's like you have to listen
We're
to the people
here.
who have more
Yeah. Like,
experience, right? So I
yeah.
think there's a bell curve, even when you're talking about interns and residents, right? So there's that group that's like this, and then there's group that's like this, and then there's the rest of the group that's in the middle that takes that
Yeah.
feedback a little bit better. So
Yeah.
I don't it would be interesting to see if there tends to be more of a cluster of overconfidence or underconfidence in certain,
Yeah.
specialty
And
areas.
how does that change over time
And how
too?
did that
That would
change?
be
But my
interesting.
guess is that there's probably a bell curve across all the
Yeah.
specialties in that
Yeah.
sense.
Yeah. That's fair.
I mean,
Um,
I'm probably wrong, but that would be
yeah.
my
Being mindful of time, because I'm excited. This has been like really good discussion, I think, which I think speaks, a lot to the article itself. I think there's been a lot of cool things to really think about. But just thinking about sort of wrapping things up a little bit. Any major take? I think we've talked about most of it, but any major takeaways from the discussion or their discussion of the limitations of the study that you all wanted to kind of highlight or explore a little further before we, wrap this up?
I think I would just say in terms of a takeaway, um, in terms of writing a methodology and writing a results section, like there are some things that I'm going to take away for this for my future work, that I thought was really, really nicely done.
Yeah, I agree. I was very impressed again by the brevity and the amount of information they were able to get into there. There are a few areas where I would have liked to see a little bit more, but in general, they packed a lot into that little five
They
page
really
plus a couple
did.
paragraphs.
I'm like super jealous of their
Yeah,
ability to like keep it brief, but like you
yeah,
said, I kept looking back and thinking this paper was longer than it was.
yeah.
Because there was so much, but they were really, efficient with their descriptions,
Yeah,
and despite like lots of good quotes, again, efficient use of them, and they were really good illustrations of the points they were trying to make. So they had some really rich conversations, it sounds like, and they selected some really good segments. So yeah, I agree. I think this is a great example to hold up for a nice qualitative research report that can be, brief, but there was still a lot of good things, right? You can't extrapolate perfectly to everything, but I think we can all still take away some really, really nice kind of pearls and tips and things, like you said, Eric, like, oh, okay, maybe I need to do a little bit more of this or a little less of that. And so I think there was also a lot of really practical stuff. And so it's a great example for me also of the impact of good qualitative research as well.
I think the other thing is that it's really important to reach out to people who know how to do good qualitative research, right? So my guess is that the cognitive psychologist brought a lot to this. One of the MDs had a Master of Education as well. And so I think that interprofessional collaboration, I think, is really awesome, and just demonstrates the quality that can come out of that, instead of us just thinking, oh, we can do this because it can't be that hard.
Yeah.
So
Yeah.
I really appreciated that too.
It can be, but when done well, it's pretty awesome. So
yeah.
So thank you to the authors for the work they did and for sharing this. And yeah, thanks for the great discussion tonight. This was a fun one. And yeah, a lot of good things to take away and learn, and hopefully, yeah, be a little bit better supervisor in the future. Awesome. Thanks, y'all.